Hello and welcome to the abdomen examination in the clinical skills of surgery. By the end of this session, you should be able to perform a stepwise abdomen examination, pick up the relevant clinical signs using your examination skills. Let's get started. Introduce yourself to the patient including your name and role, confirm the patient's name and date of birth or IC number, briefly explain what the examination will involve using patient-friendly language, gain consent to proceed with the examination, adjust the head of the bed to a 45-degree angle and ask the patient to lay on the bed. Adequately expose the patient's abdomen for the examination from the waist up. Offer a blanket to allow exposure only when required and if appropriate. Inform patients they do not need to remove their bra. Expose the patient's lower legs. Exposure of the patient's lower legs is also useful to assess for peripheral edema. Ask the patient if they have any pain before proceeding with the clinical exams. Next, position the patient lying flat on the bed with their arms by their sides and legs uncrossed for abdominal inspection and subsequent palpation. Inspect the patient's abdomen for signs suggestive of gastrointestinal pathology, and these can be scars, as there may have been previous surgeries before. Abdomen distension, which can be caused by a wide range of pathology including the 6 Fs, fat, fluid, fetus, flatus, feces or fulminant mass. Caput medusa, which are engorged paraumbilical veins associated with portal hypertension in liver cirrhosis. Striae, which is caused by tearing during the rapid growth of overstretching of the skin, seen in intra-abdominal malignancy, Cushing's syndrome, obesity, or ascites. Hernia, you can ask the patient to cough and observe for any protrusion through the abdominal wall. Cullen's sign, which is a bruising of the tissue surrounding the umbilicus associated with hemorrhagic pancreatitis, and this is a late sign. Gray-Turner sign, which is bruising in the flanks associated with hemorrhagic pancreatitis as well. Now, before beginning abdomen palpation, the patient should already be positioned lying flat on the bed. Ask the patient if they are aware of any areas of abdominal pain, and this is the area that you examine the last. Kneel beside the patient to carry out palpation and observe their face throughout the examination for signs of discomfort. You begin with light palpation of all the 9 abdominal regions. Look for tenderness, rebound tenderness, guarding, Rothsing sign, and any presence of masses. It may be large or superficial. Next would be deep palpation. Palpate each of the 9 abdominal regions, this time applying greater pressure to identify any deeper masses. So this particular examination is done to locate for deep-seated masses, their location, size and shape, consistency, mobility, and pulsatility. If the mass feels pulsatile, it's suggestive of a vascular etiology, such as an abdominal aortic aneurysm. Next, palpate the liver. Begin palpation in the right iliac fossa, starting at the edge of the superior iliac spine using the flat edge of your hand. Ask the patient to take a deep breath. As they begin to do this, palpate the abdomen. Feel for the step as the liver edge passes below your hand during inspiration. And repeat this process of palpation moving 1 to 2 centimeters superiorly from the right iliac fossa, each time towards the right costal margin. If you're able to identify the liver edge, assess for the following characteristics, which are the degree of extension below the costal margin, consistency of the liver edge, tenderness, and pulsatility. Next, palpate the gallbladder. In healthy individuals, the gallbladder is not usually palpable. But what you want to elicit here is the Murphy sign. So position your fingers at the right costal margin in the mid-clavicular line at the liver's edge. Ask the patient to take a deep breath. And if the patient suddenly stops mid-breath due to pain, this suggests the presence of cholecystitis. And that's Murphy's sign positive. Next, palpate the spleen. So you begin the palpation in the right iliac fossa, starting at the edge of the superior iliac spine, using the flat edge of your hand, and you ask the patient to take a deep breath. As they begin to do so, you palpate the abdomen with your fingers, moving up towards the left costal margin. Repeat this process of palpation, moving 1 to 2 centimeters superiorly, each time towards the left costal margin. In healthy individuals, you should not be able to palpate the spleen. However, if the spleen is enlarged, you'll be able to feel the edge of the spleen at the left costal margin, and this would suggest splenomegaly. Next would be ballotting the kidneys. So you place your hand behind the patient's back, below the ribs and underneath the right flank. Then you place your right hand on the anterior abdomen wall just below the right costal margin with the right flank. Push your fingers together, pressing upwards with your left hand and downwards with your right hand. Ask the patient to take a deep breath, and as they do this, feel for the lower pole of the kidney moving between your fingers. This is by manual method of kidney palpation and is known as ballotting. If a kidney is ballottable, describe its size and consistency, and repeat this process on the opposite side to ballot the left kidney. In normal individuals, the kidneys are not ballottable usually. However, in patients with a low body mass index, the inferior pole can sometimes be palpated during inspiration. Last but not least, palpate the aorta. Using your both hands, perform deep palpation just superior to the umbilicus of the midline and note the movement of your fingers. If your hands move outwards, it suggests a presence of an expansile mass. Now let's move on to abdomen percussion. So percussion here would involve the percussion of the liver, the spleen, the bladder, and assessing for shifting dullness. So percuss upwards 1 to 2 centimeters at a time from the right iliac fossa. And here you would want to percuss towards the right costal margin until the percussion note changes from resonant to dull, indicating the location of the lower liver border. Continue to percuss upwards at a time with the percussion note changing from dull to resonant, indicating the location of the upper liver border. And then you can measure your liver span. Next would be percussing the spleen. Percuss upwards 1 to 2 centimeters at a time from the right iliac fossa towards the left costal margin with the percussion note changes from resonant to dull, indicating the location of the spleen. Sometimes, if the spleen is not palpable, you may also percuss the spleen over the TROPS area. Next is percussion of the bladder. Percuss downwards in the midline from the umbilical region towards the pubic symphysis. A distended bladder will be dull to percussion, allowing you to approximate the bladder's upper border. And last but not least, assessing shifting dullness. So this can be also used to assess the presence of ascites by identifying shifting dullness. Percuss the umbilical region to the patient's left flank. If dullness is noted, this may suggest presence of ascitic fluid in the flank. While keeping your fingers over the area at which the percussion note became dull, ask the patient to roll onto their right side towards you for stability. Keep the patient on their right side for 30 seconds and then repeat percussion over the same area. If ascites is present, the area that was previously dull should now be resonant. That means the dullness has shifted. Next would be assessing bowel sounds. So you want to auscultate over at least 2 positions of the abdomen to assess bowel sounds, where you want to hear normal bowel sounds, which are described as gurgling sounds, tinkling bowel sounds typically associated with bowel obstruction, and absent bowel sounds suggestive of ileus, which is a disruption of the normal propulsive ability of the intestine due to a malfunctioning peristalsis. Inspect the patient from the end of the bed while at rest, looking for clinical signs suggestive of these pathologies, which are obvious scars, lymph nodes, and hernias. Sometimes hernias may be visible from the end of the bed, so you ask the patient to cough. That will usually cause the hernia to become more pronounced. Now let's quickly look at the hernia examination. Begin by assessing the groin lump to determine if it is a hernia or some other type of pathology such as a testicular mass, lipoma, abscess, or lymph node. Assess the anatomical relationship of the hernia in relation to the pubic tubercle, where inguinal hernias are typically located above and medial to the pubic tubercle, and femoral hernias are typically located below and lateral to the pubic tubercle. Next, check for reducibility. So a reducible hernia is one which can be flattened out with changes in position or application of pressure. Ask the patient to lay supine and observe for evidence of spontaneous reduction. If the hernia is present, try to manually reduce it using your fingers. The hernia may reappear if the patient stands up, coughs, or application of pressure is removed. A hernia which is tender and irreducible may be strangulated and requires urgent surgical review. Next is looking at direct versus indirect inguinal hernias. Locate the deep inguinal ring, which is midway between the anterior superior iliac spine and pubic tubercle. Manually reduce the patient's hernia by compressing it towards the deep inguinal ring, starting at the inferior aspect of the hernia. Once the hernia is reduced, apply pressure over the deep inguinal ring and ask the patient to cough. Inspect the patient's penis, scrotum, and perineum for relevant clinical signs. Look at skin changes, looking at warts or erythema, scars which may indicate previous surgery, masses, note any lumps associated with the scrotum that could be testicular cancer, or perineum that could be abscesses. Swelling, note any swelling on the scrotum which could be hydrocele, edema, and look for associated erythema that could be cellulitis. Bruising, which may indicate local trauma, and necrotic tissue, which you can consider Fournier's gangrene, which is a type of necrotizing fasciitis of the external genitalia and or perineum, and is often first noted on the perineum. Scrotal examination. So first of all, you examine the penis for relevant clinical signs, retract the foreskin if the patient is not circumcised, and check for phimosis, which is the narrowing of the foreskin. If you're unable to retract the foreskin, ask the patient to try and do this themselves. Open the urethral meatus to assess patency. Inspect the glands for abnormalities such as ulcers, warts, discharge, or scarring. Replace the foreskin once examined to prevent paraphimosis, which is a condition in which the retracted foreskin obstructs venous return from the glands, resulting in painful swelling of the glands. Next, move on to the testicles. If abnormalities have been identified during the process of inspection of the patient, or if the patient is concerned about a particular testicle, perform an examination of the normal testicle first. Ask the patient to report any pain or discomfort they experience during the examination. Use both of your thumbs and index fingers to gently palpate the whole testicle, while your remaining fingers remain placed behind the testicle to immobilize it. Palpation of the testicle involves a gentle rubbing motion between your thumb and index finger to methodically examine the whole body of the testicle. If you're unable to locate a testicle, palpate along the path of the inguinal ligament for an undescended testis. Next would be feeling the epididymis. Palpate the epididymis, which is located at the posterior aspect of the testicle. Tenderness is indicative of epididymitis. Lastly, the spermatic cord. The spermatic cord is the cord-like structure in males formed by the vas deferens and surrounding tissue that runs from the deep inguinal ring down to each testicle. Begin palpation of the spermatic cord from the superior aspect of the testicle using your thumb and index finger. The spermatic cord should be palpable, connecting to the testicle at this region. Palpate along the cord, assessing for masses such as spermatocele and tenderness. So to complete the examination, explain to the patient that the examination is now finished and provide them with privacy to get dressed. Thank the patient for their time. Perform hand hygiene and summarize your findings. We have come to the end of this topic. Thank you for your time.